at Golden Valley Health Centers. If you click on the next slide there, Natalie, I believe that's the one. Well, actually, back two slides. Back two slides is actually the clinic that I work at. And we are a community health center that's been in the Valley for almost 50 years. And we care for about 130,000 patients and have grown to over 35 clinic sites offering adult medical, pediatric, women's health, podiatry, and dental and optometry services. And here at Golden Valley, we have a long legacy of caring for the health of farmers and farm workers and really strive to give them the best care possible. And we're really a tight-knit community and just treat each other as if we're family. Go ahead and go to the next slide, if you could. And the title slide, opioid addiction. So today we're going to be talking about a very important issue and one that has affected me early in my years of training, something that I had seen and was very disturbed by and I still am today. And this issue impacts all of us, our families, our communities, and our workplaces. And it is the addiction to opioids. I wonder how many of us today on this call might know of someone, maybe a loved one, a friend, a coworker who's somehow impacted by this addiction. So I'd like to start off by telling a little story of a patient of mine. Go ahead and click on the one slide now, that'd be perfect, thank you. She was a Hispanic female. She was in her 30s, and I met her while I was volunteering at a local pregnancy center. She had just found out that she was pregnant a few days prior and was now coming to see me today for a general medical exam. And she was asking me for medication for her right knee pain. She said walking made her pain worse. And when I asked her what happened, I learned that she had an old sports injury, had some torn ligaments, and had previously undergone surgery several years back. And she had completed some physical therapy and was told by her specialist that there was really nothing else they could do. Next slide, please. So she said her specialist was prescribing her medication, 10 milligrams of Norco, a type of opioid prescription, 3 times a day. But when my patient found out that she was pregnant, she was advised to discuss pain control with her obstetrician, which was me. So I let her know that I didn't really recommend her taking opioids during her pregnancy. And thankfully she did listen, so I thought, and she went on to deliver a healthy baby boy. Now, after the delivery, it took longer than usual and a little extra push for me to get her off the opioids. And I thought everything was okay. But over the next 2 years, I came to find out that from time to time, she would ask me to write her for pain medications for her knee or some other complaint, headaches and various complaints that she had. It just seemed that she always wanted some type of pain medication. Initially, I would write her a short-term supply and make her referrals to see her orthopedist and pain specialist. I really was trying to do the right thing for her. But some years went by, and I didn't really hear back from her until earlier this year when she came to see me requesting a medical clearance. She needed to have a doctor evaluate her before she could enter into a drug rehab facility for opioid disorder. And this was the first time that she admitted to me that she was addicted to prescription opioids. And she admitted that because it was so hard to get medications from doctors like me and others, she had been stealing money to buy drugs off the street. And it really just saddened me to hear that. But on the other hand, I was very glad that she was getting help. And what she told me is that it was really when her mother found out and that she really encouraged her daughter to get into recovery and really committed to her and to support her no matter what it took. Next slide, please. So this story is still being written right now, but this story is not uncommon. And the reality is that every patient will not have it as easy as this. In fact, every day, 130 Americans die from opioid overdose. Next slide, please. And I'm showing you a chart now that shows the trend of opioid drug overdose deaths in the US over time. And if you look at the last 5 years, you'll see that there's an actual increase in how steep that curve is in deaths. And in 2017, that very last bar there, 47,000 people died from opioid overdose. And that led to our government announcing in 2018 that the opioid epidemic is a national emergency. And earlier this year, the National Safety Council also reported that for the first time ever, the odds of accidentally dying from an opioid overdose in the US surpassed the odds of dying in an auto accident. So imagine that you have a higher chance of dying from overdosing on opioids today than from dying from a collision at highway speeds on the way to work. Next slide, please. So this is a map of the US showing states that have seen increases in their death rates in the past 10 years. And my state is California in blue, and that indicates that we saw an increase during this decade. So you can kind of find your state and see if there has been a change over the last decade. Next slide, please. And this map shows the rise in drug overdose deaths from 2016 to 2017. And again, my state did see a significant rise in this time period. So how on earth did we actually get into this mess in the first place? Next slide. Well, it took us some time to sift through the data, but what is clear to us now is that in the late 1990s, there was an increase in prescribing of prescription opioid medications. The more prescriptions that were written, the more deaths from overdose. I remember seeing patients during my training who were on large quantities of OxyContin, Vicodin, in amounts that were typically seen for patients who had terminal cancer. The only difference being that these patients, they didn't have cancer. They had common ailments such as arthritis, back pain, even headaches. Conditions that were not only common, but they were also chronic in nature. They just weren't going to go away. And many of these patients were complaining to me and to other providers that they needed higher and higher doses in order to relieve their pain. And it was near impossible to get the patients to bring down their quantity of opioids because of their cravings and their fear of withdrawal from the medications if they quit the medication, or even if they missed the dose of their medication. So we as a medical community kept prescribing the medications, despite the fact that there really was no evidence that these opioids improve the patient's life in the long run. In fact, data now is actually showing that patients who take these drugs are more likely to be disabled, not less likely. Next slide, please. So I want to take a moment to highlight the three distinct waves to the crisis. The total number of people who died from opioid overdose in the United States from 1999 to 2017 was almost 400,000. The first wave came in the 1990s. And at that time, we saw a rise in the number of persons dying from overdose deaths due to our prescribing of the more common opioids. The second wave came in 2010, and at that time, we saw a rise in the number of persons dying from heroin overdose. And this was due in large part to the influx of heroin from Mexico, which was now cheaper than buying drugs on the black market, street drugs. So we saw a lot of deaths in 2010, all the way to 2013, we saw the third wave now. In 2013, we saw an increase in the deaths due to synthetic opioids, such as fentanyl, largely due to the influx of fentanyl-laced products from China. So those are the three distinct ways that we've seen here in America. Next slide, please. And this graph just is another way to show kind of what we talked about in a different way. So I want to talk about what are opioids. Next slide. Opioids are a group of drugs that bind to opioid receptors in our bodies, receptors that may be found in either our brain or our spinal cord. Now, binding of these receptors is what gives the pain relieving properties and the euphoria that these drugs are known for. So the opioids fall into three major categories. They can be natural, which is derived directly from the opium poppy. These are morphine and codeine. And then there's synthetic opioids such as hydrocodone, oxycodone, and heroin. These are partly synthetic. And the more synthetic types are methadone, tramadol, and fentanyl. Next slide, please. So commonly encountered opioids, I don't think you have that slide, which is fine, but like you may have heard of OxyContin, Vicodin, Percocets, codeine, fentanyl, and methadone, and of course, heroin, which is illegal. A few key points about the opioids so that we're all on the same page. Heroin is less expensive than pills on the black market. I mentioned that earlier, which is why more younger users, such as teens and maybe younger adults, are able to get their hands more readily on heroin because it's just cheaper. And this is what people who are addicted to opioids will get their hands on. And so a lot of the deaths that happen among heroin users are actually happening among our youth, sadly enough. Oxycodone is a prescription drug. It has a high abuse potential. You probably have seen some news recently about the makers of this drug in the courts. They're filing for bankruptcy. Anyways, this drug is something that can be dissolved in water. It can be crushed. In fact, I saw a patient about a month ago who saw me to start some medication treatment for opioid disorder. And as I looked in her nose, I saw that the cartilage in the middle of her nose was near missing. And you could see that the outer bridge of her nose kind of almost like collapsed, like it was like she was plugging her nose up with her hands. There was just no more tissue there. And that's because she was crushing up oxycodone and she was snorting it almost on a daily basis. And she ended up with a hole right through her nose. Hydrocodone is another drug that is widely prescribed. It used to be prescribed as Vicodin. Because it's so widely prescribed, patients are going to really find this on the streets and buy them off the streets. It's just widely available. And codeine is another type of opioid that comes in a pill form, but it can also be found in cough syrup. And I have a lot of patients who request medication for bronchitis and chronic coughs and really wanting the codeine syrup. And some of these people may be addicted to opioids. Next slide, please. Oh, and you can go to the next slide. Great. So one thing I want to highlight is fentanyl. Fentanyl is a medication that is one of the strongest opioids that we have. It's in fact 30 to 50 times more potent or stronger than heroin. It can actually be absorbed to the skin. And so that's one of the, you might have heard of fentanyl patches that people put on their skin for pain relief. And then more recently, fentanyl is being cut into things like cocaine and heroin. And this is really the reason for the more recent increases in deaths from opioid overdose. It's actually from fentanyl products. So why are opioids so addictive? Well, let's go to the next slide. Okay, so you don't have the slide, but that's okay. So we're well aware of the pain relieving properties of opioids. The slide before that, please, Natalie, thanks. So it does this, opioids do this by disrupting that pain signal that goes from whatever part of our body to the brain. And when I had my wisdom teeth extracted, for instance, my doctor prescribed me Tylenol number 3, which is Tylenol with codeine, which did the trick. No pain, no problem. I felt great. But the reasons why opioids are addictive has to do with the reward centers in our brain. So opioids bind to receptors within our brain, and that leads to the release of dopamine. Dopamine is a neurotransmitter in our brain, and whenever dopamine is released, it gives us the sensation of pleasure. For instance, this morning I was enjoying this hot cup of coffee before me, and some of the dopamine was released in my brain when I started drinking my coffee. And that's great. I feel pleasure. I want to do it again. So a tiny bit of dopamine was released with me this morning. I felt a little bit of pleasure. I felt great. When I go hiking in Yosemite, one of my pastimes, one of the hobbies that I really enjoy, I feel even better, right? I feel better than when I drank my coffee. And that's because my brain secretes more dopamine for that type of activity that brings me pleasure. So more dopamine, more pleasure, more feeling good, right? So this is exactly what opioids do when a person takes them. They feel this release of dopamine, this surge of pleasure, and they feel great and they want to do it again because those dopamine levels will eventually fall. And so they'll want to repeat the behavior that caused that dopamine release. Now, too much binding of opioid receptors, though, can have a negative effect. Too much binding causes unwanted sedation, feeling drowsy, confused. And this is where we get overdose deaths because too much binding of those receptors leads to death from slowed breathing. Now, dopamine release, as I said, is the reason why we repeat that behavior that resulted in the release in the first place. So my patient who snorted oxycodone, for instance, she experienced a large release of dopamine. There are lots of dopamine, probably 100 times more than what I experienced when I drank my coffee. And that's the problem with opioids. The large dopamine release, they have intense pleasure and they want to repeat that again. They want to find that pleasure sensation again. And that is what leads to this craving for that level of pleasure, so that her next high will be as good or better than her previous high. And this is a science behind addiction. This urge is so strong that it's the reason why patients will take grandma's jewelry, steal a credit card, or pawn something they own to get money just so they can buy the drugs to experience that same high. A slide we're on right now. So you can stay on that. So we know that a lot of opioid medications are being prescribed. This slide shows that more than 11.5 million people are reporting misuse of prescription pain medicine in 2016. This may be the same amount of people who are struggling today with pain medications and on the verge of addiction and lots of problems in their lives. So go ahead and go to the next slide. So of those 11 million who are suffering from misuse, an estimated 3 million actually suffer from the actual disorder. And this is defined as a problematic pattern of opioid use that leads to serious impairment in their lives. Serious impairment, serious distress. So how do we identify someone in our community, someone in our workplace? How do we know that they have a problem, right? So by definition, a patient has this disorder if they have 2 or more symptoms within the last 12 months. So let's go to the next slide and see what those symptoms are. Loss of control. This is a major feature of a lot of patients who have opioid use disorder. They have a great deal of time spent trying to get that substance, right? They're using it, they're recovering from using it, they're looking for it again. That kind of is their main focus of their day. They may say things like, you know, I tried to stop a few times before, but I can't stop, I keep starting again, right? Perhaps they say, I want to use it so badly, I couldn't think of anything else. It is their main focus of their day. They can't fixate on anything else. They can't concentrate on anything else. Perhaps you might have heard your loved one, your colleague say something like this. This is a real reality for them in their lives, loss of control. Next slide, please. And this is another area where we sort of see this more often, right? Opioid use in their lives causes social problems, right? They may experience problems at work. They may experience problems in their family relationships, right? So these are some things that we need to look out for and that we will see. Inability to follow through with commitments, inability to perform their job duties, right? Loss of trust in their boss or their coworkers. Why? Because they're missing assignments. They're not following through with things that they've been asked to do. They don't show up on time, right? Because they're using. So they're absent from work. Opioid use disorder creates a lot of problems with their work relationships, with their family relationships, and with their friends. Even things like, it says here with landlords, right? Getting rent paid on time. They're really starting to have a problem keeping their life together. Next slide, please. This is another domain of opioid use disorder, which is risky use. They're really just ignoring the risk of using and they keep using. They know that their use of this opioid is causing problems in their life, but they just can't stop it, right? They're not making what we would call rational choices. Common problem with addiction. Next slide, please. So this is just pharmacological problems. You know, when you stop the drug, they'll be in a lot of pain. They're needing to take higher doses of the drug to experience the same effect as before. So these are just common things that we'll see as well. So we went over the definition of opioid use disorder. Now we're gonna talk about opioids in the workplace. Next slide. So opioids can maybe be prescribed. How will we identify or see opioids in our workplace, right? Well, workers are gonna get injured. They may get injured after, doing some heavy work, maybe a slip and trip hazard, maybe lifting something, getting a back injury, right? This can lead them to go to see a doctor, being put on opioid medications. Opioid misuse and use tend to be higher in workplaces that have lower paid sick leave, lower job security, suggesting that individuals may feel they need to return to work quickly after an injury because using these substances will help control their pain so they can get back into work. Lack of paid sick leave, lower job security may also make workers reluctant to take time off so they can get appropriate treatment or healing. Another thing is that the effect of taking opioids can affect the safety of the worker because of the side effects. It can affect their driving, their operating machinery. They can also have difficulty with dizziness, confusion at work, vomiting, drowsiness. Opioid use can also lead to illegal drug use, right? So they might start off with a workplace injury using prescription drugs, but they might turn to heroin at this point. As a person develops the addiction, they begin to crave the drug and they continue to use it regardless of the harmful effects. So the need is to focus they start ignoring their feelings, their thoughts, their activities, and as a result, they're not focused on their work and they're unable to do their jobs safely. Next slide. Okay, so what can be done about this opioid use disorder? You know, I've given you all the bad, right? So it's not all bad. The good news is that there is a lot of hope for these patients, and that's what I want to share with you right now. There is medication-assisted treatment for these patients. There are drugs that we can use to help them, medications. And there's also behavioral therapy, you know, seeing a therapist, recovery specialist. However, I want to make a point that until the patient's craving is satisfied, all they're hearing is, I need dopamine, and I need to get that next fix, right? And so I want to caution us that yes, while we do want to help the patient and get them into recovery, get them into therapy and seeing a counselor, without calming those cravings, they're not going to be able to succeed in counseling, right? So medication-assisted treatment programs are very effective, and they're primarily using this drug that's seen right there called Suboxone. And Suboxone is an oral medication. It's approved by the FDA for use in office-based treatment. It's a long-acting opioid that really calms that craving down. And it's just dosed once a day, comes as a pill or sublingual form. And it's combined with naloxone, which I won't go into details of that, but just know that this is a great drug that can really help patients get off of opioids. Go ahead and skip to the next slide there. Okay, so this slide is showing how effective medication-assisted treatment is in reducing overdose death. And that's really the goal of medication-assisted treatment, is to prevent the patient from relapsing back into using, so that they're using Suboxone, they're not having the cravings to go use those other drugs, and their likelihood of overdosing on something like heroin or prescription drugs is greatly reduced. And so you can see the trend of deaths going down on patients who are using Suboxone. The great news is that the longer the patient's on treatment, the greater their success in relapse prevention. Okay, next slide. So this is just highlighting a program that we have at Golden Valley Health Centers that we started several months ago. And we just got off the ground. We've treated about 15 patients so far. We're part of a larger treatment center. So we are kind of like the spokes of them. And as I said, the goal of treatment is that we are trying to get these patients off of their normal pattern of drug use and onto Suboxone. And we've treated about 15 so far, and about, I'd say 95% success rate with this drug. And it's just really revolutionized this entire epidemic. And so we're glad that we can be part of the solution. Next slide, please. So what are some things that you should know, right? And what are some things that you can do to respond to this epidemic in your personal communities, in your workplaces? The first thing I would say is know what your local medication-assisted treatment resources are, so you can refer these workers over. Patients who may suffer from opioid use disorder who are willing to get treatment. You are probably already doing some of these things already, which is frequent injury prevention and training, safe lifting techniques, avoiding awkward positions when you're lifting, repetitive manual operations because those can lead to injury. Provide a mechanism for employees to make a confidential report. So when they see either themselves maybe having this opioid problem, or they suspect that someone else may be impaired in some way, they're not sure if it's opioids or not, making sure that they can make a confidential call to someone in HR or some person that can engage that person and get help. Encourage employees to discuss options for pain control with their healthcare providers. So really, I think this is part of just raising the awareness in the workplace of this opioid epidemic, and making sure that they know and are aware that this is a big problem and it can impact their lives. And providing treatment, actually offering return to work programs. So this is something where some workers might feel that if they come back to work full time, they're not gonna be able to do so without the use of opioid medications. So if there's a way that they can have a modified work, that would be this idea of return to work program that allows them to recuperate while they're returning to their full duties. And then just some normal tips on safe use of medications. Never sharing your medication with anyone else, keeping track of your pills, storing the opioids in a safe place. And one thing that we have said to our providers at Golden Valley is, look in your medicine cabinets. Where are we storing these drugs, and how are they getting in the hands of our families and children? And we just need to make sure that we're mindful of this so that it's out of reach of children and teenagers. All right, so the last slide here is just additional resources for you. And I wanted to stop there and just kind of open it up to questions if we have time for it. But I want to thank you all for your time, and yeah, I'll answer any questions you have right now.
All right, well, thank you, Dr. Deep. Wonderful insight that you have provided on this national issue. I've definitely learned more than I knew, and the progression of the types of drug options, and then very hopeful to hear about the resources and alternatives available that has really assisted in this fight against this issue. So thank you for sharing that. And again, just like Dr. Deep said, if you have any questions, please use that chat feature that we used to communicate with you this morning, and he'll be happy to answer those questions for you. So we've got the floor open for any questions. While you are thinking of those or typing those out, just want to mention again, this webinar series is a part of National Farm Safety and Health Week. We will be doing these types of webinars every Friday. Tomorrow's topic will be safety and health for your family on the farm. So thinking about that work environment when you have little ones around, son, daughter, wife, niece, nephew, just keeping everyone safe in that ag environment. Again, 8:30 Pacific Standard Time AM, 11:30 AM Eastern Standard Time. Again, I want to thank Golden Valley Health Centers and Dr. Deep for joining us today and assisting with this topic. Again, very important to be aware and mindful for ourselves, our loved ones, and our workers as well.
It's my pleasure.
Absolutely. Well, Dr. Deep and I will be on for a few more minutes. If anybody has any questions, feel free to put those in that chat box. Well, it looks like we're not getting any questions, so we are going to hop offline. Again, if you think of anything, you can contact the AgSafe office and we can get you in touch with Dr. Deep if you have anything beyond what we can answer. So thank you, everyone, and have a safe day.
Thank you.
Thanks.
Bye.
Bye-bye.